You've probably heard endometriosis described as uterine tissue growing outside the uterus. It sounds simple, but it's far from it. That oversimplified definition is actually part of the reason this disease is still misunderstood, misdiagnosed, and sometimes mistreated. The truth is, endometriosis is far more complex, and its biology explains why pain can persist even after what seems like a complete surgery. Hi, I'm Dr. Abhishek Mangeshikar, robotic excision surgeon and endometriosis specialist. Today, I want to walk you through the evolving understanding of endometriosis, what really causes it, how it behaves in the body, why some patients continue to experience pain after excision, and how all of this is reshaping the way we treat the disease. This isn't just a theoretical discussion. Understanding this biology can help you understand your own symptoms, recovery, and treatment choices in a way that's empowering and practical. Endometriosis is often oversimplified as uterine lining growing elsewhere, but that's not quite accurate. When we look at endometriosis under the microscope, the cells don't behave like normal endometrium. They have altered estrogen signaling, resistance to progesterone, and a surrounding environment that fuels inflammation and nerve growth. These lesions create their own survival ecosystem, allowing them to invade and thrive. That's why we now describe endometriosis not as misplaced tissue, but as a chronic inflammatory, fibroproliferative condition that interacts with hormones, immune cells, and nerves in complex ways. It's a systemic disease, not just a local one. And that perspective changes everything about how we approach it. The most popular theory has always been retrograde menstruation, menstrual blood flowing backward through the fallopian tubes into the pelvis. But since that happens in many women who never develop endometriosis, it can't be the whole story. Modern science shows multiple overlapping mechanisms. Some lesions probably arise from stem cells that travel through the bloodstream or lymphatic channels and implant outside the uterus. Others may develop from coelomic metaplasia, where local peritoneal cells transform under hormonal or inflammatory triggers. The real key isn't just how the cells got there, but why they survive. The peritoneal environment in endometriosis patients is more inflammatory, less efficient at clearing debris, and rich in estrogen, the perfect recipe for lesions to implant and grow. Once established endometriosis lesions don't stay quiet. They trigger inflammation and recruit immune cells that paradoxically help them survive. Macrophages, which should normally clear debris, start nurturing the lesions instead, releasing growth factors and cytokines that sustain them. These lesions also grow new blood vessels and nerve fibers in a process called neuroangiogenesis. This means that each lesion develops its own blood supply and pain wiring, linking it directly to the body's pain circuits. Over time, that network becomes hypersensitive, and pain signals start to amplify even beyond the lesion itself. This phenomenon, central sensitization, is one of the key reasons pain can persist even after successful surgery. The nerves, spinal cord, and brain essentially learn the pain and continue to perceive it long after the initial source is removed. Not all endometriosis is the same. The disease presents in different forms, each behaving differently in the body. Superficial peritoneal disease coats the pelvic surfaces with small, sometimes almost invisible lesions. They may not show up on imaging, but they can cause severe pain because they irritate nerve-rich peritoneal tissue. Deep infiltrating endometriosis, on the other hand, burrows beneath the surfaces into structures like the bowel, bladder, uterosacral ligaments, and ureters. These lesions are denser, more fibrotic, and anatomically disruptive, often leading to organ dysfunction or distortion of pelvic anatomy. Finally, ovarian endometriomas, the so-called chocolate cysts, affect the ovaries directly, damaging egg reserve and complicating fertility planning. Each subtype has a different biological signature and requires a tailored surgical approach. And importantly, one patient may have all three types at the same time, which is why cookie-cutter treatments almost never work. Hormones play a major role, but not in the way most people think. Lesions themselves can produce estrogen locally through an enzyme called aromatase, meaning that even if ovarian hormone levels are controlled, the lesion has its own fuel source. At the same time, these lesions often develop progesterone resistance, the body's natural off switch for estrogen-driven growth doesn't function properly. The result is a perfect storm of persistent inflammation and continued growth even when hormonal suppression therapies are used. This is why some patients don't get complete relief from birth control pills or GnRH analogs, and why surgery that removes the lesion environment can achieve something medication alone often can't. Many patients wonder why they still experience pain even after what appears to be a complete expert excision. It's an understandable and often frustrating concern, but it doesn't mean that the surgery has failed. It's important to remember that surgery is an act, but recovery is a process. Once the disease is removed, the body and the nervous system need time to recalibrate. After years of being in chronic pain, the nervous system often remains in a high alert state, a phenomenon called central sensitization. Over time, as the inflammation settles and the body downregulates, most patients experience gradual improvement in pain. However, if pain continues, it's vital to identify whether there are other contributing sources of pain that may be acting alongside or independent of endometriosis, such as pelvic floor spasm, adenomyosis, nerve entrapments, or even bowel and bladder conditions. As for microendometriosis, yes, it's true that microscopic foci of disease cannot be seen or removed during surgery, but current evidence does not suggest that these microscopic lesions are responsible for recurrence or ongoing pain. Ultimately, understanding that the recovery involves the nervous system, immune system, and surrounding structures helps shift the focus away from the misconception that if the disease is gone, you shouldn't hurt. Healing takes time, and addressing every layer of the pain process is part of that journey. Deep lesions are biologically distinct from superficial disease. They invade the connective tissue between organs, traveling along ligaments and neurovascular pathways. That's why they can entrap ureters or narrow sections of the bowel. They grow from outside in. Superficial lesions, in contrast, cause repeated surface inflammation that leads to scarring and organ adhesion, even without deep invasion. This is why imaging can miss superficial disease. It doesn't form a distinct mass. Understanding this difference helps surgeons plan the right approach: deep excision where necessary and gentle peritoneal stripping or vaporization for superficial disease when appropriate. Recent research is shedding light on why certain individuals are more predisposed to endometriosis. Genetics play a role, but there's no single endogene. Instead, certain pathways related to inflammation, hormone signaling, and immune regulation seem to be more active. Epigenetic changes, chemical modifications to DNA caused by environment and hormones might also explain why endometrial tissue behaves abnormally, and studies into the gut and reproductive microbiome are beginning to show that bacteria and immune signaling could influence the severity of pain and inflammation. These are early but promising areas of research that might one day open the door to truly personalized treatment plans. This evolving understanding changes how we diagnose and treat endometriosis. A normal MRI doesn't rule out disease. Diagnosis should never depend solely on imaging. Clinical evaluation and patient history remains central. Surgery, when indicated, must be performed meticulously, examining all compartments of the pelvis and even upper abdomen, since lesions can hide on the diaphragm or side walls. But surgery is not the whole story. True recovery often requires a multidisciplinary approach, involving pelvic floor therapy, pain management, diet and gut health, and sometimes psychological support to reset the pain circuits. Endometriosis is not a single entity. It's a spectrum of inflammatory, hormonal, and neurological interactions that look different in every person. That's why individualized care is the future. Endometriosis is not just bad periods, it's a biologically complex condition that deserves equally sophisticated treatment. A complete surgery is always better than an incomplete one, but it's also important to remember that sometimes no surgery at all is better than an incomplete one, because partially or poorly executed surgery can leave behind disease, distort the anatomy, and make future treatment far more difficult. The more we understand the biology of endometriosis, how it forms, grows, and interacts with the immune and nervous systems, the better we can plan and execute care that truly helps long-term recovery. If this video helped you understand the deeper science and surgical philosophy behind endometriosis, share it with someone who might be struggling with pain or confusion after a diagnosis or surgery. Awareness is powerful, especially when it's rooted in accuracy and experience. And if you'd like to see more deep dive explanations like this, where we translate research and surgical insight into real-world understanding, please like, share, and subscribe to the channel. Together, we can change how this disease is understood, approached, and treated.